Good afternoon, everyone, and welcome to the webinar. So my name is Kieran Stevens, and on behalf of Williams Medical, I'd just like to take this opportunity to welcome everyone and thank you for joining us for this webinar on understanding the menopause, symptoms, diagnosis and treatment. This webinar is presented in partnership with Newson Health, and we are delighted to welcome back Dr. Jo Sewell today. So thanks for joining us, Dr. Jo. I know it's been a very busy week for you as we approach World Menopause Day. So just a couple of bits in terms of housekeeping. This webinar is scheduled for 1 hour. We'll have a presentation of circa 45 minutes from Dr. Jo, and then there's an opportunity for you all to ask any questions at the end of the session. In terms of questions, we'd like to invite your comments and questions throughout the session. So if you do have a question, please use the chat function, which should just be at the top of your screen. I know it's working because quite a few of you have already said hello in the chat. Then one final point on recording. This session will be recorded and will be available after the session, along with some useful resources and content from the session. These will be issued as part of our post-event communication. So without further ado, I'd like to hand over to Dr. Jo to start the session.
Thank you, Kieran. That's great. And welcome, everybody. Thank you for inviting me to talk. I know I talked with you guys last year, and I think there was quite a lot of interest, so I was invited back. And as you'll be aware, it's World Menopause Month, and we're approaching World Menopause Day this weekend, which is fantastic. So I've come to talk about menopause and really talk about different things about it and possible different treatments. So menopause is becoming definitely more talked about, but there's still an awful lot of myths out there and a lot of misinformation. So we know that menopause is defined as 12 months with no periods, and it's a bit of a tricky one because some people will come having not had a period for 11 months and then develop a period, but it is 12 months with no periods. This can either be natural as we enter the menopause, or it can be induced, and that can be a surgical induction by having your ovaries removed if you've had a hysterectomy, or an ovary removed if, for example, you've had a cyst or something on them that's required intervention. But we also have a chemical menopause, and that can be from chemotherapy, which doesn't necessarily have to be chemotherapy for ovarian cancer. Chemotherapy for breast cancers, for various different cancers, can cause women to enter a chemical menopause. So in our clinic, I see very young patients. I've seen patients as young as 18 have a chemical menopause. We know that the average age for menopause is 51. A lot of women, the majority of women, will experience their menopause somewhere between the ages of 45 and 55. And early menopause is defined as between the ages of 40 and 41. And 12% of women will actually experience their menopause at this time in their life. 7% will be over the age of 55. However, 3 in 100 women will go through their menopause before the age of 40, and that's known as premature ovarian insufficiency. And 1 in 1,000 before the age of 30, and 1 in 10,000 before the age of 20. And that's a natural menopause for these women. However, the time when women often struggle to get heard is the perimenopause. And when I was studying medicine, that term didn't even exist. Perimenopause can happen for 10 to 15 years before you actually have your menopause, and that's where you're still getting symptoms, however you are bleeding. And so you'll still be getting periods, your periods could still be regular, but you're starting to get the symptoms of menopause, and this is when women often really struggle. So the history of menopause, well, we used to over 100 years, around 100 years ago, we used to live till probably 59. So we didn't spend much time in our menopause. So we'd have our children, and then we would enter the menopause, and then we wouldn't live much longer. But now we live well into our 80s, so we spend a third of our life in the menopause. And this is a time when our hormone levels are very low, our estradiol and our testosterone levels have dropped, and it's associated with numerous health risks that a lot of people aren't aware of. So we know that some people think that menopause should maybe be redefined and be called female hormone deficiency with long-term health risks, because we'd spend a third of our life. There's no such thing as going through the menopause, because once you've entered the menopause, you stay in the menopause till the day that you die. So what is the scale of the problem? Well, if you think that 51% of the population are female, we spend a third of our life in the menopause, that means 47 million women will reach the menopause every year. And 79% will have visited their GP about the symptoms, of which 7% had to visit their GP more than 10 times before receiving adequate help or advice. And this is something I hear on a daily basis. And this is probably why I'm here today too, so that we can talk about how we recognize it. Although 25% suffer severe menopause symptoms, 77% do not realize their symptoms are due to the menopause, and that's because they're not what they classically think as menopausal symptoms. 44% of women who eventually received treatment had to wait for a year or more, and 12% had to wait more than 5 years, which can be hugely detrimental to relationships, to family dynamics, and their work situation as well. So what's happening to our hormones? Well, we're going to talk about 3 reproductive hormones today. We're going to talk about estradiol, progesterone, and testosterone. And you can see this is what happens right from puberty right through to the menopause. So I see perimenopause as the reverse of puberty, and we get an increase in estradiol. It then flattens out over our reproductive years, and estradiol drops off. But before it does that, in the perimenopause, we get these real peaks and troughs, and over time, as you can see, the peaks get lower and lower. And this is often why some women will start on HRT and then say it's not working anymore. And it's not necessarily that it's not working, it's that their own background estrogen level has dropped, so they need probably a higher dose. Progesterone as well follows a similar trend, but testosterone is very different. We reach a peak in our late 20s, early 30s. It then does a linear decline, so that by the time we get to our 40s, we're functioning at 50%. So this slide is very, very busy, but I think the importance of what I was trying to make with these next 3 slides is the fact that we have hormone receptors everywhere in the body. I cannot think of a single system in the body that doesn't have them for estrogen, for progesterone, and for testosterone. So if we put them into categories, we can see here that we have them all over the brain. One of the most important things that we need to remember is that estrogen, particularly estradiol, which we have as our most dominant hormone in the reproductive years, is anti-inflammatory. It helps to improve blood flow to the brain. It helps to improve mood and reduces anxiety. It helps with temperature control in the brain. It helps to improve memory and concentration. It helps to increase levels of other neurotransmitters. So it helps with dopamine, serotonin, which is why our mood drops without it, acetylcholine, noradrenaline, and melatonin. So when our estradiol drops and those neurotransmitters drop, then melatonin drops. That's why women notice their sleep gets quite significantly affected. And that's why it improves sleep when we give it to women. It helps also to improve energy. It works on the heart, so it helps to work on the endothelial cells. It relaxes it. So it's a myth that you can't give it to women if they've got a high blood pressure. Because we tend to give body identical HRT now, it's much safer. It relaxes the endothelial cells, so actually we're reducing a woman's blood pressure. It also helps to control the heart rate. So a lot of women will get palpitations as they end up going into the menopause, and actually this will help to reduce it. So a lot of women will be given beta blockers, sent to cardiology for endless tests, come back told there's nothing wrong, but they still have palpitations, and this is the reason why. We know that estrogen also works at the level of the liver, and what it does is it improves cholesterol regulation. It also improves glucose metabolism. So we know that as we become estrogen deficient, we become insulin resistant, we have raised triglycerides, and that's why we see cholesterol levels go up and an increase in diabetes. We know that it works on the skin, that it helps to increase collagen production. So a lot of women will get skin issues, dry, itchy skin. We know, and we've known this for years, that it works considerably on the bones to help increase bone mineral density. And we know that women, prior to all the breast cancer scares, used to be given HRT as first-line treatment for osteoporosis, and still to this day it gives much better bone density and bone quality than a bisphosphonate. And it also works on the exterior cortex to increase flexibility and elasticity in the bones to help reduce fracture risk. We know it increases muscle strength, which is so important for good longevity. It lubricates the joints, which is why women often report muscle aches and pains as they go into the menopause. And we know that it helps with bowels. We know that a lot of women get IBS type symptoms around the menopause, and replacing with HRT helps to reduce this. We also know it works on the nerves. We know that women often report pins and needles. They will often report problems with what you call formication, so that it feels like insects are crawling up their legs, and actually they find this improves with HRT. And we know that we give vaginal estrogen for UTIs, and it has a huge role on bladder function and reduces the risk of infections, but it also helps with frequency, urgency, and nocturia, and definitely helps with vaginal dryness. So we know that if we give estrogen and a woman's got a womb, that we should be giving progesterone. So we know that progesterone actually plays more than just a role in thinning the lining of the womb. And actually now in our work, we tend to give progesterone off license often to women who have a Mirena coil or have had a hysterectomy, because we know it helps on the brain. We know it helps to work on the GABA receptors in the brain, so it helps to reduce anxiety, it helps with sleep. We know it helps with muscle spasm. We know it helps with bone, it regulates blood sugar, and we also know that it's very anti-inflammatory and lowers the risk of autoimmune disease, and it also helps to reduce the risk of breast cysts. And then we've got testosterone. Well, I think testosterone is a real underdog for women. We naturally produce 3 to 4 times more testosterone than we do estrogen from our ovaries. So there's a lot of people who are very scared of testosterone, and that, oh, if you take it, you'll grow a beard. That's not true. We're only replacing what women normally have. So we looked back at that slide where testosterone showed a decline. So we know that it's our most dominant hormone, reproductive hormone, for women in our reproductive years. We just don't produce as much as men. We only produce 10% of what they do. We know it's got huge amounts of roles. Currently, the NICE guidelines say we can only give it for low libido, but actually, when you look at its role, it's very important for all sorts of things. It works on the cardiovascular health to help reduce cholesterol. It improves cardiac capacity and output. It improves endothelial function. So again, it helps relax the blood vessels. It helps to reduce cholesterol production. It definitely helps with libido. It has a huge role in urinary symptoms, and that's why I really like Interosa, because as a vaginal hormone, because it really does help with women, particularly women who struggle a lot with urinary tract infections. It very much helps to improve concentration, memory, energy levels. It helps to improve muscle strength. It's also been proven to help with bone density. And it also has been shown to help with blood glucose regulation. I know something just, I think, flashed up in the chat. Actually, as of August this year, Androfem has been licensed in the UK, sadly only in private clinics for women, but hopefully that will come through on the NHS. It's been licensed in Australia for many years now, but it's also been licensed in New Zealand and I believe South Africa, but it's definitely starting to come this way. It is off, it was off label for a long time on the NHS. You can prescribe things like Testagel. So what are the common symptoms of perimenopause and menopause? Well, most people associate menopause with hot flushes and night sweats. However, 30% of women will never, ever experience this. So we do have to remember that although 70% will, 30% won't. So when they present to us, the most top 20 symptoms are these ones on the side. And we can see that a lot of those are psychological symptoms, and these are very, very common. But also other symptoms can come up that we might not think about. So we often forget that joint pain is a significant problem for women. So don't forget that. Headaches as well. And headaches are often due to a low estrogen. So people are told, oh, if you get migraines, you can't have it. Actually, often people's migraines worsen. And with the type of HRT we give now, which I'll talk about in a bit, you can give it in migraines. So these are the most common symptoms that we see in the clinic: anxiety, irritability, panic attacks, feeling low, mood swings, feeling frustrated, tearful, loss of self-esteem, and loss of self-confidence. What we also know is that with the menopause comes an increased risk of poorer health. We know that we live till our early 80s, but we know that women spend about 10 to 15 years of that in poorer quality health than our male counterparts. We know that 1 in 2 women will get osteoporosis, and we know that actually taking HRT reduces that risk by 60%. We've already talked about when we become estrogen deficient, we become insulin resistant, so we're more at risk of type 2 diabetes. And by the time women get to their 60s, they're at the 30% increased risk of type 2 diabetes. We know that when women take HRT, even women who've got diabetes already, they get much better blood glucose regulation. So those patients who you might see who've got type 2 diabetes and poor sugar control, glucose control, it's because their hormones are probably affecting it. And often when they start HRT, their levels actually settle. And also because of this insulin resistance, they can end up becoming more obese in the menopause. And we know that we've got all those receptors on the brain, so there's an increased risk of dementia, and 2/3 of dementia patients are female. We know that there's an increased risk of clinical depression and suicide risk goes up in women around the time of perimenopause. And we know that the biggest cause of morbidity and mortality in women after the menopause is heart disease. And by taking HRT, you can reduce that risk by 50%. So I thought I'd talk about a case study. It's the same case study I use. I apologize for any of you who watched this last year, but I always think it's a really good one because it covers so many of the symptoms. So Laura was actually an NHS worker herself. She was 46. She was a midwife in a very busy hospital. And the symptoms she was noticing was she wasn't sleeping as well. She was feeling exhausted. She was anxious. She was low in mood. She developed poor concentration and poor memory. She had a loss of confidence and she had worsening migraines. She put some of it down to stress at work. I mean, working as a midwife in the NHS is a very stressful job, but her mother had recently been diagnosed with dementia. So again, she was thinking, well, that's extra stress. She started to become overwhelmed. Her anxiety worsened. She couldn't remember names or words, which also made her think, was she starting to get early dementia? Her confidence had dropped. She was worried that she was going to make a mistake at work. She was getting 2 migraines a week. Previously, she had a tendency to get them around the time of her period, but now they were getting much more significant. She was getting vaginal dryness and cystitis and never having had a history of UTIs really before, and she couldn't really understand what was going on. Her periods were getting much heavier, they were lasting longer, and her cycle had slightly shortened. She'd previously been 28 days and not having any problems, but now she was having to use a tampon and a pad and changing that quite regularly. Laura was advised her symptoms were nothing to do with her hormones when she went to see her GP, as she was still having periods. Okay, so this is the point that I was trying to make earlier about the perimenopause, and also because she'd not had any hot flushes or night sweats, but we've already mentioned that 30% of women will not get that, and her blood tests were normal. Well, blood tests aren't very reliable in the perimenopause because our hormones are up and down, so you won't actually achieve a lot with taking an estrogen, and even an FSH isn't always reliable because of the fluctuations in the hormones. So she was given an antidepressant. She was also given diazepam for her panic attacks, but she found that none of it was working. So she was signed off work, and then sadly, she didn't feel any better. So she didn't feel she could work safely, especially as her job was high risk. So she handed in her notice, and that was a huge thing for her because she had been the main earner in her family because she was quite a senior midwife, and it financially caused a lot of problems for them. So I'm just going over to show you this now because I find often talking to women, if you start to think, right, they're in their 40s, they're still having periods and they're on they've got getting a lot of psychological symptoms, I would direct them to the Balance app, which has got a symptom checker on there. You can put all the information in, they can download it, and then you can assess it. And actually, it's got loads of great information. It's got loads of medical content, but and it's got lots of treatment advice on there for patients. So they can feel quite empowered, and they could bring it back to you to sort of see where things are. So she came to the clinic and we actually gave her an MSQ, which is our symptom questionnaire, and realized that she wasn't, she was suffering quite a lot of symptoms and scoring quite highly. And so we put her on some regulated body identical. Now, body identical is different to bioidentical, which isn't regulated in the United Kingdom. But body identical has got the same molecular structure as our own hormones, and it's much safer than the older synthetic hormones. It's more natural because it's made from yams. And we give our HRT generally first line as this. So we generally give our estrogen through the skin. So we gave her patches and progesterone because she had a womb and she was still getting her periods, but we gave her sequential because she was still getting her periods. 3 months later, she felt better on her HRT. But so we had to do a few little tweaks with it, but we also added in testosterone because she was still getting a lot of cognitive symptoms as well as low libido. 9 months later, at her next follow-up, she'd felt entirely back to normal, and she'd actually returned to work as a midwife. And interestingly, at her annual review, 15 months later, she'd applied for a promotion and was successful in becoming a senior ward manager on the midwifery wards. She described that it had improved her quality of life. It was transformational. Everything in her life, relationship-wise, had improved, and definitely her finances. She was no longer feeling low in mood. She had better libido. She had no further symptoms. But what was also interesting was she was then able to exercise and eat and drink healthily. So that was also going to help her mood and her symptoms as well. And her shoulder pain had gone. She had no more stiffness. The benefits for the employer is obviously they had a frontline worker back in employment. She'd taken promotions, the workplace were getting the best out of her, and she'd saved the sick pay because she was being treated appropriately. So what we need to think about is, what does this mean for the NHS? Well, we know that because of the shortened appointments we have in primary care, I am an ex-GP and I only left recently. You don't have a lot of time. And I can remember when we used to say, well, what's your most significant symptom? Well, for a person who's perimenopausal or menopausal, they'll have more than one. So you might not necessarily understand it, which is where the Balance app comes in. She had been to the GP numerous times, and we could save numerous GP appointments, particularly if we know that women are attending up to 10 times to get their before they get given HRT. It would save the NHS a lot of unnecessary investigations, which also comes with a lot of costs. It would also reduce waiting list times. We know that if you look at the different specialties which are listed here, things even like maxillofacial, because women get a burning mouth or cotton wool mouth that they're referred in for. A lot go to rheumatology because of chronic fatigue and get diagnosed with fibromyalgia. If you look at all these, actually you would save, it actually comes out as being billions that would save the NHS. So let's talk about HRT. Well, 75% of women say they don't know enough about HRT to make an informed choice. When people get told, what would you like to do? They don't know enough themselves. Around 2000, in the 2000s, around 26% of women were taking HRT. That figure dropped significantly after the breast cancer scares with the WHI, down to 5%. And in 2022, it come back up to 14%. But women and healthcare professionals are still worried about the perceived risks. So the guidelines now, the NICE guidelines, the IMS guidelines, which is the International Menopause Society, all say that HRT is first line. But what it needs to be is individualized care. So it's not a one size fits all. It's no different to prescribing thyroxine or insulin. Okay, we need to do it for the patient, what their needs are, what their symptoms are. We know that young women need to have hormones at least until the age of 51. So if they have an early menopause, for whatever the reason, they need to have their HRT because of the health risks. But for the majority of women, the benefits now from the newer body identical HRT outweigh any risks. So they can take it for as long as they need. There's no maximum length of time for taking HRT. It's not like when I learned and you had to get them off it by the age of 60. My eldest patient is now 89 and has been on it since she was 51 and has no other drug history, no other past medical history. But women are still worried, and like we said, healthcare professionals are worried, and it all goes back from this worry about breast cancer. And we know that that study has actually been debunked because they didn't have a very big population size. They didn't do a baseline mammogram on those women. They looked at quite an elderly population up to the age of 79. And we know as we age, we naturally are more at risk of breast cancer. They didn't look at confounding factors. We actually now know that, yes, synthetic HRT does slightly increase the risk by a further 4 per 1,000 on top of the background risk of 23 per 1,000. But things like alcohol increase the risk more at 5 per 1,000. A BMI of over 30 increases your risk by a further 24 per 1,000. So actually we should be talking to women about their lifestyle because it's more of a risk of breast cancer than the type of HRT. So we know that there's no increased risk of breast cancer in women who are young. So up to the age of 51, there's no increased risk with HRT. We now know that there's a lower risk in breast cancer in women who take only estrogen. So women who've had a hysterectomy, only needs that, they have a reduced risk by 7 per 1,000. We know that not all progestogens have the same risk either. Okay, that we know that the dihydroprogestogens have a less risk. It's more the medroxy, the MPAs have an increased risk, and any risk is associated with older progestogens. But actually, this risk, like I said, isn't as big as we think. And the body identical HRT with the microionized progesterone shows the same breast cancer risk as if you're not taking HRT in the 5-year studies that have been done. We also know the clot risk has changed significantly. So if you're taking estrogen through the skin as a patch or a gel, it doesn't get broken down in the liver. You therefore have no increased risk of blood clots. So even if you've had a clot, even if you've suffered with migraines, there's no increased risk. And microionized progesterone is not associated with an increased risk of blood clot. And the Thrombosis UK Society website shows that, and they don't need to come off it for surgery either. We know it's not a one-size-fits-all, and we know there's lots of different preparations. So we know that absorption gets affected by the type they take. So some women might find patches brilliant, but we know that skin thickness, skin temperature, skin hydration, blood supply into the surface of the skin all affect absorption. So if they're not absorbing an estrogen patch, you may want to go over to a gel or vice versa. And that's why sometimes they need a slightly higher dose. So just by starting, that's why I'm not a big fan of Evril Conti and Evril Secret, because you just stick it on and then you can't alter the doses. And also they might need more progesterone because they're bleeding. So we need to talk them through the different options. Sometimes women get progesterone intolerance, so they get worsening anxiety, low mood, and they're often the women who struggled with the pill when they were younger. And if they did, we can look at taking eugegestin vaginally. Yes, it's off-label, but as doctors and nurses, we prescribe 20% of everything we do is off-label. So it's not uncommon to do it like this. There's also different types. Cyclogest often works really beautifully. It was initially worked as a progesterone for PMDD in the 70s, 80s, and 90s. More recently, it's used for fertility treatment in women who get bleeding and miscarriages in the first trimester. But we find it works really well for bleeding and for women who are progesterone intolerant. We know that you can take pills, but I would always use those as the absolute last option if they're maybe struggling with absorption. But patches and gels would be my first line, and then the sprays is also an option. We know that it helps to improve symptoms and quality of life. We know it reduces the risk of osteoporosis, diabetes, heart disease, as we've talked, osteoarthritis, dementia, depression, and all-cause mortality is reduced by 30% if women stay on it over the age of 60. These are quotes from some of the patients we've seen in our clinic, and generally they just feel like their old selves, which is great. But we know that it's not the silver bullet. We need to be doing it in conjunction with lifestyle. So diet is really important. I always talk to women about increasing their fiber intake, eating the rainbow, 30 different plant points across the week, and making sure they have enough fiber and protein. Because if they are putting on weight, it's really important that they look at their diet. We know that your basal metabolic rate reduces by 15% as you go into the menopause. So it's important that maybe smaller portion size, but we might have been able to get away with those few sneaky treats, but it's much harder to lose that weight when you're menopausal. Exercise is really important. We know that it helps with the vasomotor symptoms. We know that muscle strengthening is vital for women as they enter the menopause, and that also improves their basal metabolic rate. We know it helps their bone density, but we also know that exercise reduces your risk of breast cancer by 7 per 1,000. So when you're looking at that breast cancer risk, it's really important. We know that women who smoke have increased vasomotor symptoms. We know that obesity as well is associated with increased symptoms. We know that women find that their anxiety and their vasomotor symptoms worsen with alcohol. And we know that as we go into the menopause, our alcohol dehydrogenase enzyme does reduce, so we can't process the alcohol as well. I recommend all my patients take a vitamin D supplement of 1,000 international units alongside eating enough calcium in their diet. Sleep is vital. Sleep is vital for symptoms. And if we often can't work well on our sleep without our hormones, that's some of the problems. But sleep hygiene, relaxation is important. And regards to supplements, I always recommend vitamin D. I like the omegas for the brain health. A lot of women find magnesium helps with their restless legs, which is also often due to low estrogen and low iron. But magnesium is often very calming, and taking it with a good B complex is great. And a lot of women who struggle with their skin issues, zinc. But with regards to alternative therapies like black cohosh and red clover, none of these things are evidenced or regulated, and some of them can actually cause liver dysfunction. And bioidentical is we don't know if they're getting enough progesterone, etc., in it to protect the womb. So we do need to be very careful when we're advising about that. But if women can't take HRT for whatever reason or don't want to, there are other options. Antidepressants at a very low dose can help with night sweats, as can gabapentin and pregabalin, but we do have to remember that they come with side effects as well. Oxybutynin has been found to help with night sweats as well, and hot flushes, but CBT can really help for anxiety, hot flushes, and the CBT for insomnia works very well for a lot of patients. Problem is sometimes those hot flushes come in the middle of the night, and that's when CBT is not quite so effective. So why should organizations take menopause seriously? Well, we know it's a huge problem. We know that 59% of women had taken time off work due to their symptoms. 21% did not go for a promotion they would have normally otherwise considered, which is really sad. 18% were off for more than 8 weeks. Now, that has a huge impact to them financially, the business, their colleagues, because they're taking on more workload. And 12% will resign. Sadly, 12% will never return to the workforce, which I find is huge, and that's just not really good enough. So there's a lack of menopause awareness and support, and it's costing the UK economy £10 billion a year. When you count the cost of staff leaving, recruitment costs for rehiring and training replacement staff. But what's also sad, if women are leaving early or going for demotions, going part-time, then they face up to a £30,000 pension shortfall, which is awful. So if we look at it, the mental health costs are quite significant, and the menopause, the NHS. Cardiovascular costs are also quite high, as are hip fractures, diabetes, dementia, and the financial burden of migraines. So menopausal women taking HRT have a reduced risk of all of these conditions and can bring the cost down and the waiting list down. So what can organisations do? We need to change the culture and remove taboos. The fact we're here now And we need to be putting menopause guidance, support groups, talks, and provide menopause education for all. We need to empower with evidence-based medical resources and tools to help women make the informed choices about their health and treatment options, because I think a lot of healthcare professionals still have a lot of fears about it. And I think if we could all work together as a team collaboratively, we could make a big change. If we understand the impact of hormone changes, that will help women in the workplace, and advocate for our staff, so that we help to remove barriers and allow them to thrive at work, and sign them to resources and organisations where they can get help. A lot of organisations do have champions, which is great, changing the culture, encouraging, I think, a healthy lifestyle, because I think a healthy lifestyle is really important as well. But what we have to remember is that there are barriers to this, because currently one of the biggest things we were told that women find hard, about 30% of women find really difficult, is the cost of exercising, cost of food. And that's because of the cost of living crisis. So we do need to think about that. So it's not always accessible for everybody. Again, there's the resources here with the Balance app, as we've talked. And since using the app, these were the numbers that we found had helped. So 87% said they've been able to self-diagnose. They felt empowered to go and talk to somebody about it. 62% said their mental health had improved. 74% said they felt more comfortable about talking about it. And I think that's huge. Just being able to talk and realise they're not going mad, that's really important. 69% had started HRT treatment versus 14% of the UK population, which is quite interesting. 54% said their physical health had improved, and 40% said they'd missed fewer days at work. So really the take-home messages I want from this today, if that's all right, is the menopause is more than just hot flushes. So just because somebody doesn't have them, don't say to them, it's not your menopause, you can't be perimenopausal. And low hormone levels cannot be replaced without taking HRT. HRT provides more benefits than risks for most women, and women should receive individualized advice, but we need to be mindful of other stresses and the impact of what poor sleep, weight loss, or weight management does, and look at them holistically, and have a look at the website and Balance app. Even as healthcare professionals, that's really helpful. And there's the app, and there's our building in Stratford, where I am currently at the moment. And I was joking with Kieran about how my kids would laugh if they knew that I had a QR code on the system, because I literally cannot cope with new technology. So there is a Confidence in Menopause program, which for those of you that would like to learn a bit more, it's a certified course that is CBD accredited, and there's lots of information on there. And then, yes.
We've had a couple of questions submitted by the audience. I know you've answered a few as we've gone along, but yeah, as a reminder, if you do have a question that you've not yet submitted, please pop it in the chat box and we'll try and get through as many as time allows. But thank you, Dr. Jo, a very informative session once again. I'm sure everyone will all agree. Just from our perspective, this is our second webinar back after our summer break, and I'm pleased to confirm that we'll be delivering more education throughout the winter months. So please keep an eye out on our webinar registration page for future events. And as an attendee of this session, you'll also be notified about these events. So we'll be delivering other clinical sessions along with 3 new sessions as part of our practice support series designed to support you in your day-to-day roles. So I'll just give everyone a couple of seconds just to pop any more questions in. But yeah, from a Williams Medical perspective, as one of the leading partners for healthcare professionals in primary care, we are dedicated to supporting your everyday, both from a service perspective and also through added value and education, as we've been able to deliver in partnership with Dr. Jo and Newson Health today. Our offering spans across numerous medical services, along with thousands of products in our disposables, pharmaceutical and equipment categories, including our women's health range. We're very proud of our excellent rating on Trustpilot, and just want to reiterate that we're here to support you and help you save time and effort with our omni-channel shopping experience. And if you pop to the next slide, Jo, just before we go back to the questions, I'd just like to remind everyone that you can earn rewards every time you shop with Williams Plus. This is our new reward scheme at Williams Medical. You can find out more about your eligibility and enroll by visiting the website on screen, which is wms.co.uk/Williams Plus. So before we bring the session to a close, Jo, I'm just going to check the chat section.
Yeah, I got that up as well. So do you want me to, I can see there was one about testosterone. I hope I covered that. So is not licensed. No, it became licensed in August for Androfarm. The gel version is Testogel, which has been licensed for men for years. Ironically, most of the prescriptions currently done in the UK for Testogel are for women. It's a really great product. It's probably what you can access in the NHS. And I used to, when I was an NHS menopause specialist, I used it all the time. I still use it more than Androfarm because I actually think absorption of it's fantastic. If you don't feel confident prescribing it, you can refer to an HR menopause specialist in the NHS. I know they exist because I was one. There's not a lot of us, or weren't a lot of us when I was doing it. Or if you think your patient has got access to a private clinic, they could go there, but I would go with that as an option. Because yes, testosterone is really important. And I hope that in the next few years, we'll start to see the testosterone change and become more available for women. If you're on an anastrozole for breast cancer, been advised should not have menopause treatment, how can this be overcome? This is a very tricky one because anastrozole, as with all aromatase inhibitors, blocks all estrogen. So you can't have it because it won't work, the estrogen. There's some great work coming out of America by a Dr. Rebecca Glaser. Now, what we do know is that you can take vaginal hormones safely if you've had breast cancer. The systemic absorption from vaginal hormones is the equivalent of 1 milligram estrogen tablet over the course of a year if they take it for a year. And that's even if they take it every single day. So the absorption is minimal. So it's absolutely safe. And these women are usually in severe discomfort with vaginal dryness and urinary symptoms. So they can take whatever they find most comfortable to use, whether that be Vagifem, Vagirux, Blissel, Estriol Cream, Invagis, usually an e-string. I love an e-string, but often they can't use it initially because it's too uncomfortable to insert it, or they can use Interosa. However, going back to Dr. Rebecca Glaser, she's been doing some work with testosterone and vaginal hormones with women on AIs. And actually, testosterone has been working well. Again, you'd probably want to refer into a menopause specialist for this. But if you want to look at her work, Dr. Rebecca Glaser, spelled Glaser, and a lot of my patients, testosterone can help a bit with hot flushes, can definitely help with bone and muscle aches and pains. It can help with all the cognitive things. So a lot of women find that, but you need to go to a menopause specialist. So if on HRT, what is the next for general pain and tiredness despite good diet and exercise? I'd be wondering, are they absorbing? Yes, we talk about the maximum dose of HRT being licensed at 100 microgram patch or 4 pumps of estrogel. There's a lot of misunderstanding about that because actually when the big study was released in December of last year, they looked at 1,500 women over 6 months and they found 20% need higher than the licensed dose. And actually, if you look at dosing, it isn't linked to, there was another study that was released in the summer that didn't show that there was any increase in endometrial thickness. So I would look at maybe, do they need to go slightly higher? If you don't feel confident doing that, again, refer into a menopause specialist, maybe change the type of HRT they're taking. So if they're on a patch, is it sticking well? The estrogen is in the adhesive. So I would actually want to know what their compliance is like. Also, if they're using gels, are they pumping it all onto one hand and shoving it on one limb? You need to make sure that each pump is on a different limb. Are they rubbing it in really, really well? Do that. There's all this myth that you should put it on the cap and rub it in on the cap. Why? You're wasting it. It should be going into your skin. Put it on your hand, give it a good rub in. So I would look at that and see what's going on there. Okay, sorry.
I was just going to say, Dr. Jo, in terms of the questions about resources, if you're happy, the slides where you had the pointers and the resources,
Yeah.
we will include them in our post-event comms, if that's okay.
Yeah, absolutely. So what HR treatment would you use for a woman who'd had a full hysterectomy but in early 40s? Would you use both estrogen and progesterone? I definitely start them on estrogen. They're going to be crying out for it. If they've had their ovaries removed, they're probably going to need testosterone. Unfortunately, when women have a full hysterectomy, I don't think they're advised enough about what their symptoms are going to be feeling like. And the most common phrase that women use is, I feel like I've been hit by a bus. So I would definitely start them on estrogen. They're probably going to need a reasonably good dose of estrogen. A lot of patients will need definitely up to the 100 microgram patch or 4 pumps of estrogel or 2 to 3 milligrams of Sandrina, and often higher because they've come from their levels being a lot higher. I actually think those women need testosterone, because remembering that 3 to 4 times more testosterone is produced than estrogen from your ovaries. If you're not feeling confident, maybe speak to the consultant they're under or refer them into a menopause specialist. Progesterone is good for them if they feel like they're still have some anxiety or their sleep's not great. Then I would give 100 milligrams of Eugegestin off label, and a lot of them really like it. A lot of women love their progesterone, so that's really important. So a Mirena coil in situ causing periods to stop, will this affect the diagnosis of perimenopause, particularly in a younger woman? No, it won't. They'll still have the normal perimenopause. The great thing is they've got a good progestogen there, so you can just stick on some estrogen, see how they respond. And again, if you feel they need testosterone according to what the slides say, I'm looking at that testosterone slide, then do refer them in. But no, get cracking on the hormones, because often they have Mirena, it makes them feel better, but they need a bit more estrogen as well. And other studies are similar about digestion. Well, in the perimenopause, there's not. Unfortunately, there's a lot of lack of studies in women's health, but we do know that all 3 hormones can affect digestion. I actually find if you get, particularly women who maybe suffer with IBD, they get a lot of flares around the perimenopause. And often if you get their hormones back on track, particularly getting them in a good optimized level, then actually their digestive symptoms improve. But no evidence that I'm aware of, I'm afraid. Is that everything?
Brilliant. Yeah, I think that's all questions covered. Oh, we've got one more just dropped in from Sophie.
Oh, do you always need to see a deficiency in testosterone? I'm still a bit old school. I am BMS trained. I like testosterone and sex hormone binding globulin. Sex, so that we can work out free androgen index. I think you need to look at all 3. And I also think you need to remember that what we don't know is how high those women's levels were in their late 20s, early 30s, because it's a range, it's a spectrum. So some women feel a lot better with just a little bit of testosterone. Some people need a lot more, particularly women who have had polycystic ovaries. They are going to be crying out for testosterone, and that's what makes them feel unwell, because they've functioned with much higher levels their whole life. I do advise, the guidelines do suggest that we get baseline levels and show it show that it's low, but with the free androgen index, which you can just type in free androgen calculator, just pop their testosterone and their sex hormone binding globulin in. We want the free androgen index between 2 and 5% usually for women to feel better. And if they've had polycystic ovaries, they've often functioned with it up around 7% or more. So yeah, I look at the whole thing in conjunction with their symptoms, because I don't think you can maybe take a totally isolated testosterone, because if they've got if they're super fit, super healthy, they're going to have a higher level of sex hormone binding globulin, so that's going to bind all their testosterone up, so their free androgen index will probably be low and they will need it. Okay, I hope that's answered everyone's questions.
Brilliant. Yes, I think that's all questions covered. So to bring the session to a close, once again, thank you, Dr. Jo, for joining us today. And thank you to everyone else who has joined us on this webinar. We'll follow up this session with the resources discussed in the session. And yeah, please don't hesitate to contact us if you need any support. I hope you have a good day. And we look forward to seeing you all on some of our future webinars.
Thank you.